Okay, let's talk about aneurysms. This is under the concept of perfusion. Your book does not list this as a specific exemplar. It does list it under intracranial regulation, talking about strokes. So, kind of aneurysms or aneurysms, but this is certainly a perfusion issue, and we're going to talk about aortic aneurysms as we go through this. So, what is an aneurysm? An aneurysm is actually a weakness of the vessel wall causing an output pouching or dilation of that vessel wall. So, this is just an example, a JPEG. I like to go to Google, find things that have good pictures. So in the first one, you can see that we've got that pooching dilation right as the aorta is coming off the heart, right out of the left ventricle. So think about that. That's a real high pressure system there. The next picture in the middle shows it right after the aortic arch there. Those are probably the most common. And then the last one that shows it down below the kidneys, down in the thoracic area. So that is what an aneurysm is. You may also hear the word dissection related to these, and what a dissection is the innermost layer of the vessel wall has pulled away from the rest of the vessel, and because of that, we have like a pouch that blood can go into, and so as it goes into the pouch, it's not going further, and we certainly have a decrease in perfusion. So that can happen with these, can certainly just happen like post heart cath. I've seen they have a little dissection of a coronary artery when they're in there doing a heart cath. That's what I'm most familiar with, but I'm certainly a cardiac nurse, so you can see these. Your aneurysms involve the aortic arch, the thoracic or the abdominal aortic aneurysm. So AAAs, if you have somebody who's had a AAA repair or has a AAA, can be congenital or degenerative conditions. It does tend to run in families and certainly related to trauma, penetrating trauma, which is something you got impaled by something, or blunt trauma. MVC is what's considered blunt trauma, so they can develop an aneurysm there. I actually have seen this happen, and I guess it's happened more than once in a carotid artery. Patient was fine, had no risk for that, was actually in for other problems. The nurse looked over, saw a big pulsating mass that literally just appeared in their carotid. So that's pretty interesting. All right, so let's talk about risk factors and prevention because this piece is important. So risk factors, we have, it's a lot of cardiovascular risk factors. We do have things that would be considered modifiable and things that are not modifiable. So does occur later in life, 60 to 70 years, is more common in men. Doesn't mean that women don't get it, just more common in men. Certainly if you have hypertension and CAD, a family history of aneurysms. So if you have a family history of aneurysms, you do need to be screened for that. If they use tobacco, certainly that's, according to your book, that's the most modifiable risk factor. I can't change my age. I can't change my gender. I can't control my hypertension and decrease any other CAD risk factors, but certainly tobacco is easy to do. High cholesterol. If they could have lower extremity peripheral artery disease, PAD. They could have carotid artery disease, so they could have carotid stenosis. Those patients are at high risk for having strokes. Carotid stenosis usually leads to things like endarterectomies. They may have had a previous stroke. Obesity is a risk factor, and then congenital abnormalities like Marfan syndrome. So what Marfan syndrome is, it's people who are very tall, very thin, and have unusually long arms and legs. So you notice specifically when they have their arms out at shoulder height, they have a really longer than expected distance between their fingertips to fingertips, and it is speculated that Abraham Lincoln probably had Marfan syndrome. So that is a connective tissue disorder. So our prevention certainly is risk factor reduction and control, and then to find out if we have a family history so that we can monitor those patients. Okay, so let's talk about clinical manifestations. So, the first one is that this is often asymptomatic and patients don't know and may be found during routine exams. So that could be a routine chest x-ray or abdominal x-ray for whatever reason, and they're like, oh hey, you got an aneurysm in there. And if it's small, they will continue to monitor it, have them come in on a routine basis, and wait for that to get bigger before they do anything about it. Could be found on routine exams that you hear vascular sounds or what's called the bruit in their abdomen when you listen to bowel sounds. That is abnormal. If you listen over carotid and hear a carotid bruit, that would be abnormal. So when you listen over carotid, you have the patient hold their breath so that you don't hear breath sounds, and you should hear nothing. If you hear swish swish of the blood, that tells you the patient has a carotid bruit, and so that's significant. So the thoracic aneurysms, they can have back and chest pain. They may have that pain while they're lying supine. They can have dyspnea, cough, hoarseness, some dysphagia. AAAs can have flank pain, chest pain, that visible abdominal pulsation, an abdominal bruit. They may express having abdominal throbbing or feeling their heart beating in their abdomen. That is absolutely not abnormal. So if they tell you those kinds of things, that's important. When this ruptures, this is life-threatening, and we're going to talk about that at the end. They'll have diaphoresis. They'll be pale. They'll be weak. They've got tachycardia, hypotension. They'll have abdominal, back, groin. Could have periumbilical pain. Could have changes in LOC because of poor perfusion. That pulsating mass. And then the words you never want to hear is ripping or tearing sensation in their chest or their abdomen. That is that aneurysm trying to dissect. So let's talk about collaboration. Certainly we need a healthcare provider. We may need a surgeon. We may need a radiologist. Because some of this repair can be done in interventional radiology or even done by a cardiologist. We might need respiratory therapy if we're having some breathing difficulties, pharmacist, dietitian to work on taking antihypertensive meds, doing risk factor reduction, all of those types of things that are important for prevention. So how are we going to diagnose this? So the best thing is actually a CT of the chest and or abdomen, and they're going to see it. Specifically, if you're coming in, we're like, holy Hannah, this patient seems like they may be having an aneurysm. We're going to want to get them to CT. Certainly could be picked up on a chest x-ray. An echocardiogram would pick it up certainly as it's coming off the top of the heart, because an echocardiogram is that sonogram of the heart. An MRI might be done because we get better pictures of MRI than anything that we have. They could do an angiogram, which is shooting dye into the artery and watching it. We would need to look at a CBC because we would be interested in what their H&H is. We might do cardiac enzymes or cardiac markers or biomarkers. Think of troponin and a 12-lead EKG just to rule out that this is a myocardial infarction because of the chest pain, shortness of breath, all of those other signs and symptoms that do seem to be the same as an MI. We just need to rule that out. We certainly need a coag panel because if it's rupturing or they need to go to surgery, we need to know what their coagulation state is. Are they taking an anticoagulant? But remember, if they're taking apixaban, which is Eliquis, Pradaxa, Xarelto, those do not change their coag panel, so we would need to know what medications they're taking, and we would need to type and cross them. Because they're at risk for hemorrhage and bleeding and shock. Okay, so treatments. So pharmacology, we need fluid, blood, emergency medications if it ruptures. They will be on things like antihypertensives, so beta blockers. They could be on ACE inhibitors, lipid-lowering agents like a statin. Those would be patients who are at risk for or who have a small aneurysm that we are watching. So interventions, if they're small, they're just going to watch them. Routine follow-up. whatever that looks like, whatever their provider wants for them, and we're just going to watch that. The small ones are less likely to rupture, so that is okay. So repair could be transcutaneous with a stent, so they do something along the lines of think about a heart cath, put a stent in their aneurysm, just think that's actually a really big stent, or it could be an open surgical repair, which is a much bigger surgery, much more difficult because they're going to have a large incision and have more rehab time from that. So post-op care, we need to think about assessing cardiac and respiratory status, make sure that assess them for dysrhythmias, make sure they're hemodynamically stable, so looking at vital signs, O2 sat monitoring. Complications, certainly infection, VTE if they've had an open surgical repair because they need to get up and walk. We need to look for any kind of neurological complications from blood loss and poor perfusion. We need to watch fluid and electrolyte balance and certainly pain control for those patients. All right, so complications. The biggest complications for these people is if this sucker ruptures. And this may be somebody who has absolutely no idea they have it, and we have a medical emergency that needs prompt resuscitation and surgical treatment. These patients are going to code on you. So this could be somebody walking in the ED, and it could be that patient of yours sitting in a hospital bed that you had no idea. So what are they going to have? They're going to have bleeding, massive hemorrhage. They're going to have hypovolemic shock. They're going to get tachycardic. They're going to be hypotensive. They're going to be pale, clammy. They're going to be weak because of that perfusion. They're going to have decreased urine output because they're bleeding and we have poor perfusion. Altered LOC. They'll have abdominal, back, groin, periumbilical pain. Abdominal tenderness, that pulsating abdominal mass. So those are those same signs and symptoms we've talked about. And that dreadful ripping, tearing sound. So what you need to know is the risk factors, the prevention of those modifiable risk factors, certainly family history. We really got to get on those people. Watching blood pressure, do not smoke, cardiac risk factors. And then what to do if they come with this suspected aneurysm that is rupturing and provide emergency care for them. Thanks.